As part of the CME criteria, please be aware this is a CME accredited event. There are no commercial sponsors of this grand rounds. Disclosures were reviewed and no conflicts of interest were found. Okay, so first up we have Rachel Greenberg, who is originally from Great Neck, Long Island, and graduated from the University of Pennsylvania with a bachelor's in psychology. She then matriculated at the Albert Einstein College of Medicine, where she has pursued several research projects in urology, ranging from the ethical considerations of surgical management of children with DSD to analyzing risk factors and comorbidities in a population of stone-forming adolescents. During her free time, Rachel enjoys cooking and baking and has developed several original pastry recipes. She also likes to explore the outdoors and is an avid hiker, skier, and snowboarder. She has done a great job on service over the last 3 weeks and will be presenting today on the management of BCG refractory non-muscle invasive bladder cancer. Come on up, Rachel.
Good morning, everyone. So for those who haven't met me yet, I'm Rachel, and thanks for the introduction, Dr. Mamadinia. So today, again, I'll be speaking about BCG-Unresponsive non-muscle invasive bladder cancer. And no financial disclosures, thanks, Jody. And the reason I decided to speak about this today is because bladder cancer is the most common malignancy of the urinary tract, with its incidence approaching 10 in 100,000 in men and 2.5 in 100,000 for women. About 75 to 85% of bladder cancer is actually non-muscular invasive. And perhaps most pertinent to everyone here, there's updated AUA SUO guidelines providing new information on the risk stratification and clinical framework for the management of BCG unresponsive disease, as well as non-muscular invasive bladder cancer in general. So our index patient today is a 67-year-old male former smoker who was referred by his PCP for hematuria on and off for 3 months. His past medical history and past surgical history is non-contributory, and he has no allergies. His family history also non-contributory. With regards to his social history, he did have a significant smoking history, but no other chemical exposures as they relate to bladder cancer. On physical exam, all within normal limits, as was his GU exam. And labs were also all within normal limits, except for a UA, which showed 28 RBCs per high-powered field. It was also significant to note that he did not, at the time, show signs of a urinary tract infection. He underwent subsequent follow-up and workup for his hematuria, cytology showing atypical urothelial cells, with a CT urogram showing a filling defect in the dome of the bladder, and subsequent cystoscopy showing an exophytic mass as well as at the dome of the bladder. An exam under anesthesia at that time was negative for any palpable masses. A TURBT was conducted revealing high-grade T1 disease, and he subsequently underwent repeat cystoscopy with TURBT, again confirming T1 disease 6 weeks later. Patient is now status post 6 weeks of BCG induction therapy, and he has a follow-up cystoscopy scheduled. So in terms of agenda for today, I'll briefly review non-muscular invasive bladder cancer, as well as provide an overview of BCG therapy and go into sort of the definitions that surround BCG unresponsiveness, as well as the updated guidelines that help us define this disease, and go through management options and future directions as they relate to BCG refractory patients. Now, non-muscular invasive bladder cancer, again, comprises 75 to 85% of bladder cancer, and the World Health Organization characterizes these lesions into both flat lesions and papillary lesions. And you can see here that there's CIS disease, which are generally considered flat lesions, papillary lesions, TA disease, and T1 disease, which invades the lamina propria, but not through the muscularis propria. And TURBT is considered the initial treatment management for visible lesions that are non-muscular invasive. In terms of its therapy, so BCG has generally been considered a standard of care therapy since about the 1970s for non-muscular invasive bladder cancer. It's comprised of an inactivated strain of Mycobacterium bovis, and it works to upregulate both the Th1 and Th2 responses primarily through the immunomodulators IFN gamma and IL-10. Interesting to note is that it's thought to work primarily through the Th1 response, and I'll go through a little bit of what happens when patients might upregulate a Th2 response as opposed to a Th1 response. So the AUA SUO guidelines provide us with indications for who should receive BCG therapy. And this is their risk stratification for patients with non-muscular invasive bladder cancer. And generally, patients with intermediate or high-risk disease are those who qualify for this treatment. And this is comprised of individuals with either large low-grade lesions or high-grade papillary lesions, as well as any CIS and T1 disease. The induction course has been considered, generally been considered a standard of care by Morales et al. To be 6 weeks in course. However, studies have shown that a 6-week induction is not sufficient for optimal response, and that a maintenance course is required as well. Now, there are several opinions on what should constitute a maintenance course, but follow-up at 3, 6, 12, 18, 24, 30, and 36 months provided by the SWOG in 2000 is generally considered the optimal course of therapy, and this has been shown to reduce the risk of progression by 27% in patients. So as the AUA and SUO guidelines state, adequate therapy is considered more than 5 of the 6 intended induction doses, as well as more than 2 additional weekly doses, or a second reinduction dose in a 6-month period. Now, how do we define BCG failure or BCG unresponsiveness? So approximately 40% of patients will not respond to BCG, and among individuals who demonstrate an initial response, more than 50% will actually recur. Each additional BCG course failure carries a 7% actuarial risk of progression of disease. But despite this, in more than 30 years, only 3 drugs have been FDA approved for its management. And partially this is because studies in non-muscular invasive bladder cancer are hampered by a lack of consensus on trial endpoints and appropriate control arms for studies. So the International Bladder Cancer Group has been systematically addressing these issues, both by defining low, intermediate, and high-risk disease, as well as providing the standards of care of management for each risk category, and providing definitions of outcomes such as recurrence, treatment failure, and disease progression. Historically, there were several definitions surrounding BCG failure, and this includes BCG intolerance, or an inability to tolerate it due to side effects or toxicities, BCG refractory patients who never actually show a response to BCG therapy, and BCG relapse, in which a patient might exhibit an initial response to therapy, but subsequently will reoccur. And this prompted the International Bladder Cancer Group to come up with a more standardized definition of treatment failure, because the complexity and ambiguity of these definitions were really hampering these studies. So BCG unresponsive disease is now considered a combination of both BCG refractory patients and BCG relapse patients. And what has come about from standardizing this definition is that patients can now be considered for single-arm studies where control groups aren't necessary. So with regards to etiology, a patient may not respond to disease due to insufficient or excess BCG. And the response to BCG therapy appears to be a dose-dependent one on a bell curve where the maximal response is actually seen in intermediate doses. It may be due to extravesical or metastatic disease, and this was shown by Burka et al., who showed that about 50% of patients who didn't respond to BCG therapy were due to the fact that they actually had a synchronous disease that was not identified at the time of initial diagnosis, or an inadequate or waning immune response. So over time, the Th1 response might be downregulated with an upregulation of the Th2 response. Now, with regards to management options, having provided all these definitions, I thought it would be useful to go through the state of the management options that exist to date and the state of research that's going on in this field. And this is a flowchart from the AUA and SUO guidelines that I mentioned, and I know it's a little bit hard to follow, but I've highlighted what I'll be speaking about today. So an intermediate or high-risk disease, you can offer these patients after TURBT, induction therapy, or BCG therapy. I can use this. And if they do recur, you might consider an additional course of induction BCG therapy, but inevitably cystectomy has been considered the gold standard in the management of non-muscular invasive BCG unresponsive disease. Now, if patients are unwilling or unfit to undergo surgery, you may consider referring them to either a clinical trial or other intravesical chemotherapies. And this will be kind of the focus of what I'll be going through in the upcoming slides. Now, importantly, the NCCN also had updated guidelines in 2017, and they seem to provide very similar recommendations. So you can consider change in intravesical agent or cystectomy for TIS or TA disease, but for high-grade disease, cystectomy, again, is the gold standard of treatment. So what forms the basis for these guidelines? So radical cystectomy was shown to be the gold standard of treatment in a study published by the BJU International looking at patients with CIS disease, in patients with CIS disease after radical cystectomy. And they actually looked at patients both who did receive BCG therapy and who did not. And we'll be focusing on the 71% of patients who received prior BCG and failed therapy. And what they looked at was their main outcome was recurrence-free survival. And they showed that at 5 and 10 years, the recurrent-free survival rates for these patients were 94 and 90%. So it was highly successful. And in the 4 patients who didn't respond to this therapy, it was actually due to a synchronous tumor that was present at the time of diagnosis that was actually not identified. The takeaway being that radical cystectomy for CIS disease is treatment with excellent outcomes for patients with BCG non-responsive disease. It's not just cystectomy, but rather early cystectomy, which is of crucial importance for these patients. So this study published by Aaron Sagani showed that 307 patients had BCG, and 90 of these patients subsequently underwent radical cystectomy. But it was the timing of radical cystectomy which differentiated the treatment arms. So about half the patients underwent radical cystectomy within 2 years of their initial BCG therapy, and the other group, the radical cystectomy was delayed till after 2 years, and this was usually due to either patients not wanting to undergo cystectomy or surgeons not offering it because they may have seen that the patient might not be medically fit for surgical management. And in their 15-year disease-free survival, they showed that patients with early radical cystectomy had much better outcomes than patients who underwent late radical cystectomy, 92 versus 56%. The takeaway being that not only should we offer radical cystectomy to our patients, but the timing of the surgical interventions is of utmost importance. So as of 2017, radical cystectomy is the only standard salvage therapy available for patients with BCG refractory disease. But in light of the high risk of cancer progression in this setting, placebo comparisons are unethical, so single-arm trials are acceptable. So what that's led the International Bladder Cancer Group to do is kind of define a threshold as to what's considered a positive response to therapy, because we don't have controls here. So it's generally been considered that a 30% recurrent-free survival at 1 year and a 25% recurrent-free survival at 2 years is considered a positive response to therapy. So these are kind of the intravesical options that are available today or in the works of being developed, and we can categorize them generally into the categories of immunomodulation and chemotherapeutic actions. And I've highlighted kind of what I'll talk about here today. So I'll preface the upcoming slides by saying that there's a lot of research into different chemotherapeutic and immunomodulatory therapies, and there's a lot of outcomes in these studies, but what I've decided to do is highlight the recurrent-free survival in each study so that we can more effectively compare each therapy. And I'll have a summary slide where we can kind of look at how the outcomes of the different therapies compared to each other. So BCG-IFN combination therapy has been thoroughly studied, and the thought was that IFN has been shown to upregulate the Th1 response by inhibiting IL-10. However, it has been studied as a monotherapy, and results from that trial showed pretty poor responses with about 22 response rate at 1 year and 8% at 2 years. So researchers decided to combine it with BCG, which has been shown to be highly effective for these patients. So in this study published in the Urologic Oncology Journal, it's in a phase 2 trial looking at this combination therapy. There was 1,007 patients recruited, and they looked at BCG naive versus BCG failure patients. So again, the BCG failure population is what we're more focusing on. And what they showed is that at 2 years, the BCG failure patient showed a 45% recurrence-free survival when given BCG-IFN therapy. Researchers also conducted a multivariate analysis looking at certain risk factors or baseline characteristics that might predict response to BCG therapy. And this might include older age, people would be less likely to respond. TA disease is more likely to respond to this combination therapy than T1 disease. And prior BCG therapy, like multiple rounds of therapy, so more than 2 rounds of induction therapy, was associated with a poorer response. The takeaway being that there are consistent response rates for both patients with BCG naive disease and BCG failure disease at 2-year follow-up. MCNA is also a new immunomodulatory therapy that's been studied. It stands for mycobacterial cell wall nucleic acid complex. It's actually similar to BCG in that it's an inactivated mycobacterium, but it's Mycobacterium fleae instead of bovis. And this study published in the Journal of Urology looked at how patients would respond to a 6-week induction course of MCNA. And in their recurrent free survival rates, they showed 25% survival rates at 1 year. And you can see in the different, I've outlined what the different lines represent, but TA disease responds better than CIS and a combined TA and CIS disease. And in the bullet points on the right, you can also see that patients with BCG relapse disease actually responded much better than patients with BCG refractory disease. So obviously this didn't perform as well as the combination therapy, but another therapy to consider for these patients. Now, with regard to chemotherapeutic agents, valrubicin is, again, currently the only FDA-approved treatment for these patients. And this study published in the Urologic Oncology looked at a similar population. 80 patients received 800 milligrams of valrubicin, and their response rates were actually pretty low. So at 6 months, it was 22% recurrent free survival, 10% at 1 year, and 4% at 2 years. So what I thought was interesting about this is that how is it the only FDA-approved medication if it's been performing, more poorly than the 2 that I've already presented? And we'll see how it compares to the other chemotherapeutic agents. So gemcitabine appears to perform much better than valrubicin. And the reason it's been studied is it's been shown to be effective as a systemic therapy in patients with bladder cancer. So 47 patients underwent intravesical gemcitabine therapy, and they showed a 1 year and 2 year recurrent survival rates of 28 and 21%. And this actually spurred the NCCN 2017 guidelines to suggest gemcitabine, and it's the only chemotherapeutic agent that they actually address in their guidelines to be an alternative therapy to patients who don't want to undergo or are unfit for radical cystectomy. So docetaxel has also been studied, published in the Journal of Urology. 54 patients with BCG failure or BCG-unresponsive disease, and again, a 6-week induction therapy. And what they showed is that the 1 year survival, disease-free survival was 40% and 25% at 3 years. And in terms of the induction versus induction and maintenance, although the relationship didn't reach statistical significance, they showed that patients who received both induction and maintenance tended to respond to therapy better, and this approached statistical significance but did not need it. So intravesical docetaxel appears to be an efficacious agent with significant response durability for BCG failure patients. So again, this is the summary I was referring to earlier. So we can see by comparing disease-free survival or recurrence-free survival at these different time points, although the time points weren't consistent, we can kind of form some conclusions about the state of these immunomodulatory and chemotherapeutic agents. So you can see that this BCG combination therapy appear to be the most efficacious, second only to radical cystectomy, but that docetaxel also appears to have a pretty good response for these patients. And I just wanted to mention, there's a lot of research on these different agents. I couldn't go through all of them, but there do exist studies looking at mitomycin, other combination chemotherapies and combination chemotherapies with immunomodulation. And there are still ongoing clinical trials, which I'll touch on in a second. So where are we in the management of these patients? So this is a phase 2 clinical trial that's hot off the press, and it's looking at instillidrin. So how this immunomodulatory agent works is it's recombinant adenovirus, so RAD. Sorry, I lost my mouse. Whatever. It's recurrent adenovirus, and what they've done is they spliced out the replication portion of the virus, and they replaced it with IFN, and they're able to induce it intravesically with SYN3, which is a surfactant that allows for easier translocation of the drug into urothelial cells. And in this study of 40 patients who were assigned to either low or high dose disease, the phase 1 trial is actually looking at the efficacy of the drug itself, and this was looking at different doses. Patients were followed up at 4, 7, and 10 months, and at 12 months with random biopsies and of the index tumor. And their primary endpoint, again, was freedom from high-grade disease at 1 month, so recurrent-free survival at 1 month. And they had a 35% response with recurrent-free survival at 1 year with no difference between doses. The interesting thing was that many people suffered from adverse effects, so that's something to consider moving forward. And these patients are still being monitored, so they're looking at a 3-year endpoint at this point, still collecting data. So how does that compare to the rest of them? So going back to this table, docetaxel still appears to work a little bit better, but it did have improved responses when compared to the other agents that we spoke about. So in terms of future directions of therapy, research is going on looking into being able to predict BCG failure, so different genomic sequences or epigenetic factors such as genes that affect the immunomodulatory response, genes that modulate the glutathione pathway to detoxify cells. Additionally, researchers are looking into trimodal therapy for BCG-unresponsive disease. And more targeted therapies are also being pursued, such as davotinib, everolimus, and pacinium. And they're also looking into intravesical delivery therapy. So similar to that SYN3 surfactant that I was talking about, this suggests that it might not be the drugs itself that we should look into more, but rather how can we more effectively deliver these drugs to the target cells. And so in summary, BCG-unresponsive refers to this combined group of BCG refractory and relapsing disease. As of right now, radical cystectomy is the only standard salvage therapy for these patients. Cystectomy can be associated with high rates of morbidity and mortality, so many patients might not want to undergo this surgery. But currently, the only FDA-approved intravesical therapy is valrubicin. And current studies are underway exploring intravesical immunotherapy and chemotherapeutic agents. And I wanted to take this opportunity to thank you for allowing me to speak today, and for so far an excellent month here, and I look forward to next week as well. I hope I get to work with more of you.
So what do you think is going to happen in the, do you think any of these other agents will be approved by the FDA? Are you aware of any of the challenges facing?
I'm not aware of the discussions of the FDA right now, but I assume based on some of the results of these studies that I know they were, the FDA discussed MCNA as a therapy and is actually rejected. But the basis for rejection of that study was that it was a single arm trial. So I'm hoping that with the new AUA SUO guidelines saying that single arm trials are actually okay for this population, because it would be unethical to use a control group because radical cystectomy is so successful. It sounded like they were going to reconsider potentially that therapy.
Yeah, I mean, that was the main driving force for the AUA kind of making that statement, is that we've had gemcitabine and now doxorubicin as possible uses that are much more effective than valrubicin. I mean, and we've recognized that for many years. I mean, gemcitabine, even though the studies are relatively recent, has been recognized as a better alternative to valrubicin. Almost no one uses valrubicin. I mean, even though it's approved, we all will go straight first to gemcitabine and now trying to get docetaxel.
In terms of, there's a big concern about BCG shortage. I don't know if there's any indication, and I don't think it's discussed openly, about moving some of these advanced agents into the first line in light of this anxiety about the scarcity of BCG.
So one of the studies that I don't think I ended up presenting was a sequential BCG's gemcitabine therapy gemcitabine docetaxel sequential therapy. And the reason that it was, I think it was in Australia, and the reason that that hospital actually did that study was because of the BCG failure. And I think the response rates were actually much better than using BCG. So, I mean, they're definitely pursuing that. They were in like phase 2 and discussing their experience with using that alternative therapy, but they did say that the reason they even did it was just because of the shortage.
Great.
It's a great summary, great overview. There are a couple other trials also to make BCG more effective. We don't have them open here, but there's a SWOG Prime trial. And the thought is, if you've been vaccinated against maybe BCG, you're going to have a more robust response. So that's a randomized trial to giving someone a vaccine, the BCG, and then putting them on either the US strain of BCG versus the Tokyo strain to see that. And then the other thing which is going on is medical oncologists are, they're using, there's about 4 new checkpoint inhibitors now approved, darvalimab, avelumab, nivolumab, and pembrolizumab. They're all PD-1 or PD-L1 inhibitors. But SWOG has a trial where they're giving atezolizumab, which is one of the checkpoint inhibitors approved for metastatic disease, to patients systemically. The concern is there's never been any preclinical data that if you give a checkpoint inhibitor, there's going to be a robust immune response in the bladder. It's a very hard trial to run because medical oncologists have not historically treated non-muscle invasive bladder cancer. So it's very hard to accrue to that trial because patients are going to be shuttled between medical oncology and urology. But if there are ambitious urologists, there are some folks like Peter Black, another guy at Oklahoma, who are actually learning to give these agents and are giving them in their own clinic to stimulate the body's immune system. And then Pat has been trying to open the RAD recombinant adenovirus for 2 years, but because it's a viral-based therapy, there's a lot of regulations, and that trial is accruing. It's a phase 3 trial through the SUO, and there are currently about 50 to 60 patients on. The trial is 140 patients, and they've accrued pretty well in a year and a half. So maybe that's a registration trial, so they will bring it to the FDA, and they'll look for approval based on that phase 3 trial.
I just have to make a biological question comment of, I don't know if we're ever going to find this, of why a bladder cancer becomes muscle invasive versus non-muscle invasive. What are the set parameters in the biology of the cancer that crosses a sort of point that we treat so differently? And if we can find, obviously it's not going to be one thing because everything's so complicated, but we don't even have a clue. I think you address that with some markers that you might want to look at, but I've always wondered why don't we have that set of panel right in front of us. And then I thought, for another biological question is about the stem cell origin of bladder cancer and how that might affect treatment, because, the concept of clonal origin of the cancers, and I thought you were going to mention some genetics, Brian, but you didn't. But anyways, I think those are all important points that are going to tie into what kind of treatments that we're going to give.
Okay. Next up, we have Daniel Siegel, who was also born and raised in Long Island in New York, and he had a 3-year stint in Israel during his early childhood. He earned his BS in biology with a minor in chemistry and geography from UNC Chapel Hill. followed by a year of conducting research in the NY Institute for Reconstructive Plastic Surgery. He then began medical school at SUNY Downstate in Brooklyn. Danny played competitive volleyball in high school and college, and you can still find him bump setting and spiking on the beach when it's warm. He is an avid runner, having competed several half marathons, which is 1/6 of an Ironman, and he enjoys exotic travel. We've enjoyed having Danny on service this month, and today he will be presenting on adjuvant therapy and high-risk localized RCC.
Thanks, Dr. Monomedinia. For everyone who doesn't know me, I'm Danny Siegel from SUNY Downstate. Yeah, it's a little embarrassing. I heard you guys have had some Ironman competitors here before, so thanks for mentioning the half marathon. But I'm up here to talk to you guys today about adjuvant therapy for high-risk localized renal cell carcinoma. I have no financial disclosures. We'll start with a case. We'll start with a 63-year-old female. By her PCP from the routine lab work, she was found to have microscopic hematuria. She had no significant past medical history, past surgical history, taking no medications. She was an occasional recreational drinker, and she used to smoke, I think, about 10-pack-year smoking history, but she'd quit 40 years prior. Physical exam was unremarkable, except for some mild fullness in the left upper quadrant. And as part of her hematuria workup, a CAT scan was completed. I'll show you some representative images here. Hopefully, looking at this, something looks a little abnormal here. To draw your attention to the left kidney, where you can see a large renal mass. And I'll scroll through some pictures here. There was some concern looking at these images that there might have been some involvement with the pancreas or nearby spleen or some other structures. The official read here read a complex 8.8 by 6.4 by 7.4 mass. The left kidney demonstrating enhancing components. After discussion with the patient, it was agreed to undergo a left radical nephrectomy, and the nephrectomy was performed without complication. My understanding was that in the surgery, the mass was able to peel off the pancreas rather easily, and there were no complications in that regard. So prior to surgery, going into surgery, this was clinical T3 disease, stage 3, localized, high-risk renal cell carcinoma is what we were expecting. So the question for today is, after a patient like this with high-risk disease, after nephrectomy, what are our options moving forward to follow such a patient? Well, we like to go to our guidelines to guide our management, obviously, and the NCCN guidelines recommend observation in such a patient. For stage 3 patient after nephrectomy, they basically just recommend frequent H&Ps, lab work, and imaging is clinically indicated. Our AUA guidelines tell us similar results. Also, they recommend observation with imaging as well. The question now is, well, if we took out the tumor, why do we even need to follow them? Well, that's pretty obvious. We always worry about recurrence and relapse, and renal cell carcinoma is no different. Renal cell carcinoma actually has a high risk of relapse after nephrectomy, and I've just highlighted a line here taken from a study, and it's reproduced and quoted a lot, that there's a recurrence rate between 20 to 40% for high-risk localized disease in RCC. So clearly, observation and surveillance is appropriate, but is there something else that we need to be doing to try and reduce this amount of recurrence? And that something else would be adjuvant therapy. Now, the general model I like to think of when you think of adjuvant therapy, and that a lot of different disease processes go through, is that drugs are proven to be effective in the advanced metastatic setting. We then take these drugs and we'll apply them in randomized controlled trials after resection of localized disease. And then we'll monitor and alter our guidelines based on the results of these studies. Well, this isn't anything new to renal cell carcinoma. Actually, starting back in the early 2000s, this was done with the traditional immune therapies. These therapies, such as IL-2 and interferon alpha, were looked at extensively in the adjuvant setting. This is just a review slide about adjuvant therapy, and these are 4 large studies that were looked at in the early 2000s, looking at these drugs such as interferon alpha and IL-2. And basically, what was shown was that there were many different drug trials, many different drugs, many different populations, and all the results were negative. So traditional immune therapies were no good. Then the idea of vaccine therapies came up. Things such as giving patients autologous irradiated tumors, heat shock proteins, BCG. And again, this is another meta-analysis that was completed on 2 large studies of vaccine therapies, also showing no significant effect in the adjuvant setting. So we have these traditional immune therapies and these vaccine therapies. no effect. So what am I here talking to you about adjuvant therapy about? Well, the debate's actually not dead. As recently as this last May at the AUA conference, there was actually a point-counterpoint debate about adjuvant therapy for high-risk renal cell carcinoma. This is Dr. Wood from MD Anderson and Dr. Harshman from Dana-Farber, and they were discussing the role of targeted therapies, VEGF inhibitors specifically, in the adjuvant setting. Now, these VEGF inhibitors make perfect sense for renal cell carcinoma. Renal cell carcinoma is a highly vascularized disease, and so it's thought that this is a very logical theoretical attack on the disease. A lot of renal cell carcinoma has a mutation, this VHL HIF1 alpha mutation, that makes these tumors angiogenesis dependent. So naturally, cutting off blood supply, cutting off angiogenesis would be a good mechanism to attack this tumor. As you see here, these are just some VEGF inhibitors, and the main point here, I'm not going to get into depth about the mechanism of action, but they all ultimately affect the pathway to stop angiogenesis. Well, so these drugs were looked at and were thought to be used in the adjuvant setting. So lots of trials were started, and these trials recently started to be published. The data recently started to get published. The first trial that came to publication was called the ASSURE trial. This trial was published in The Lancet, and it looked at disease-free survival with adjuvant sunitinib and sorafenib after nephrectomy. These are two VEGF inhibitors. The primary outcome, as I mentioned, disease-free survival. Secondary outcome, they also looked at overall survival and toxicity. This was a large study comparing these two drugs and two treatment arms to placebo. I had about over 1,900 patients, and what I just want to draw your attention to early on is that there was a large amount of dropout in this study. If you look in the two treatment arms, just roughly eyeballing the numbers here, almost half of the patients had dropped out for the study, and this will be important later on. Some more points to mention as far as the demographics here. They included 80% of their patients were a clear cell subtype. Now, this makes sense as it's the most common renal cell carcinoma subtype. However, that means 20% were non-clear cell. So not a completely homogeneous group here. Additionally, as far as their inclusion criteria, they allowed anyone from T1b and greater to be included in the study. That's a pretty wide range of disease stage. And the last thing to mention is their UCLA risk score, the risk for recurrence. They allowed people from intermediate or above to be included. As far as the results for the trial, you see the Kaplan-Meier curve here. There was found to have no treatment benefit for disease-free survival. You see the traditional curve here, there's no separation from early to late. What about for overall survival? Also, no benefit for survival. So between sunitinib, sorafenib, and placebo, you can see there's no real separation between either of the curves, and there's no statistically significant treatment benefit. So no benefit for disease-free survival, no benefit for overall survival, and actually it was found to have a high amount of toxicity. The toxicity was so great that it caused two effects in the study that are pretty important to mention. The first effect is that they allowed dosage reductions in the study. For example, in the sunitinib arm, you would start at 50 milligrams. They allowed reductions to 37.5 and then even further down to 25 milligrams. So that's a dosage reduction of half that they allowed in the study. Then further, actually halfway through the study, they had to change their protocol so that everyone that they were enrolling would now start at the 37.5 milligram initial dosage. This was not intended by the study designers, and that's something to keep in mind. But this had such an effect that if you were in this study by the third cycle of, by your third drug cycle, subjects in the sunitinib arm were only receiving about 40% of their intended dosage, and subjects in the sorafenib treatment arm were only receiving about 30% of their intended dosage. So the conclusions of the ASSURE trial were pretty powerful, saying there was no treatment benefit for adjuvant VEGF inhibition. In fact, in the conclusion, in the closing statements, the authors of this study argued strongly against the use of any anti-angiogenic therapy in the adjuvant setting whatsoever. Pretty powerful. So in early 2016, when this came out, you might have thought targeted therapy, all hope is lost. However, a couple months later, the New England Journal of Medicine published this STRAC trial. This was another clinical trial looking at sunitinib, and specifically in a high-risk renal cell carcinoma after nephrectomy. This was a smaller study, about 600 patients, only two treatment arms here, looking at sunitinib and looking at placebo. And again, I'll just highlight the discontinuation, the dropout rates here were also pretty high for the treatment arm. As far as the breakdown and inclusion criteria in this study, they enrolled a higher risk group overall. the patients had to be T3 or higher, stage 3 disease, and they were also all clear cell. So keep that in mind. So while there's a smaller sample size in this study, it's maybe a more homogeneous group and maybe a better study design in that regard, making everything more homogeneous. So it might be more clinically relevant. As far as the results, they did find a longer duration of disease-free survival in the sunitinib treatment arm. As you look at the curve here, you can see the separation between the treatment arm and the not treatment arm from early to late that maintained throughout. They found a statistically significant hazard ratio of 0.76, meaning that you're 24% less likely to have recurrence in this time period if you were given the treatment of sunitinib. One important thing to point out as well in the study design here is that the primary outcome was disease-free survival as determined by a centrally blinded independent review board. So when they also had their own investigators determine disease-free survival, but only when the central independent review board looked at the data was the data statistically significant. And this held up also when they did a secondary analysis looking at the highest risk subgroup. When the central review board looked at the highest risk subgroup, they found a statistically significant 2.2-year treatment benefit, which is greater than the original 1.2-year benefit. But again, it was only with the blinded review. The investigator analysis alone did not find a statistically significant difference. So disease-free survival potential benefit here. What about overall survival? The overall survival, unfortunately, was not mature at the time of data cutoff. But if you dig through the appendix, you can find this chart here that shows your overall survival data that they published at the time. And unfortunately, it looks like there's no trend towards benefit, though it's not powered to comment on this yet. And we need to wait until they reach their endpoint to see what the actual overall survival is. As far as toxicity, they experienced high amounts of toxicity. Discontinuation rates were about equal to the ASSURE trial, about 45% discontinued in this trial. Dosing, though, there were dose reductions, but dose reductions were limited from 50 to 37.5. So overall, perhaps a higher dose intensity in this trial. Again, so conclusions here that there is potential for disease-free survival benefit with sunitinib. So we have these two trials looking at very similar outcomes using very similar drugs and very similar designs, but we have drastically different results. So I just quickly like to go over what could potentially account for the differences between these two trials. We talked about most of these, but just to review, one would be the patient selection. In the negative ASSURE trial, they had a more all-encompassing group, perhaps, with lower stages, lower risk groups, and non-clear cell renal cell carcinoma subtypes. Additionally, as far as dose intensity, we mentioned that as well. That shouldn't be discounted completely. There seemed to be a lower dose intensity in the negative ASSURE trials compared to the STRAC trial. And lastly is the idea of this blinded independent central review that found significance in the STRAC trial, whereas there was no blinded review in the ASSURE trial. So perhaps this showed some investigator bias towards placebo, which, who knows, maybe the investigators didn't want to jump the gun too fast, or there might be some bias there, but it's unsure. Well, the EAU saw these two studies. They saw that there was conflicting data. So in February 2017, they published a meta-analysis on this data. And they also found no statistically significant treatment benefit for disease-free survival in using sunitinib. Now, they compared the ASSURE trial and the STRAC trial. However, I want to point out that the meta-analysis is weakened here by the fact that there's only two trials. The trials are weighted pretty unfairly with a much heavier proportion in the ASSURE trial. And also there's a large heterogeneity of inclusion criteria between the two trials. So overall, the EAU recommended against adjuvant sunitinib in the high-risk clear cell renal cell carcinoma subgroup with a recommendation rating of weak due to the weak power of the meta-analysis. With all this debate, and there was a lot of talk between the two trials, why is one positive, why is one negative, so the authors of the ASSURE trial actually went back and, because they were getting a lot of pushback on their study design, and they updated their results. They published a separate subgroup analysis on their results, looking specifically at the high-risk cohort that they had and only clear cell subtype. And when they did that, again, they found no treatment benefit for disease-free survival. They were also getting pushback based on the dose intensity, like we talked about. And so they broke down sunitinib and sorafenib. They broke down within each treatment group different quartiles of dosage intensity to see if there was a benefit or if there was a statistically significant difference between those patients who received the highest dose, the lowest dose, or anywhere in between. And while it appears like there may be some difference for those receiving the lowest amount compared to the rest of the group here, that's the blue line on the bottom in both curves, there was actually no statistically significant difference here. So the authors are stating, yeah, we may have had lower dosage, but clearly it doesn't have an effect. And the same when we look at all of our analysis, the same way that STRAC did, there's no effect. However, I want to put this statistically speaking, this wasn't the most accurate way of analyzing the data. Performing a subgroup analysis post hoc is might be frowned upon slightly. Realistically, you're supposed to run what's called an interaction term analysis in order to be allowed to run a subgroup analysis like this, which they didn't do. I mean, that gets into heavy statistics that a lot of us don't like to even think about, but they did it regardless. They found the results, but at the end of their paper, they actually state we were not powered to find any statistically significant difference. So that says something on its own. So just to briefly summarize these adjuvant VEGF inhibitors, some potential pros, I'll phrase it that way, are that there could be a 1.2-year disease-free survival benefit like that the STRAC trial showed. That benefit could be even greater, shown to be up to 2.2 years, with the greatest benefit being in the highest risk subgroup with clear cell histology. Some cons, though, are that there's an unproven overall survival benefit. There's high amounts of adverse events, high amounts of toxicity. And lastly are these two ideas that I find really interesting, the law of diminishing returns and angiogenic switch. Now, in basic science, the theory behind these recurrences is that you have these micrometastases spread through the body after you remove the tumor. These micrometastases are not yet angiogenesis dependent. There's a point where these tumor cells grow and reach a certain tumor burden that they then switch, that this angiogenic switch, to become angiogenesis dependent. So that's where the law of diminishing returns comes in, that in the adjuvant setting, exposing these tumor cells that are not yet angiogenesis dependent to these anti-angiogenic factors, you're really having no effect, but you're actually exposing them to these drugs and potentially building a tolerance down the line when, if they do recur, you might be reducing the efficacy of a proven drug in the advanced metastatic setting. But thankfully, there are some more concrete answers likely on the horizon, especially in regards to these targeted therapies. Here's just a table breaking down some of these clinical trials. On top is the ASSURE trial that I mentioned at depth. This with negative results with sunitinib and sorafenib. The STRAC trial were the positive results with sunitinib. I'll point to the PROTECT trial. Data was also recently came out in this trial at ASCO in June. And it was published in abstract and presentation form, so I couldn't read through everything. But I think the gist of it is that they had found negative results also. There's one other trial I want to point to here, the Everest trial looking at everolimus. This is an mTOR inhibitor actually, but it still works on that same pathway. So hopefully coming soon in the next couple of years, we'll have a concrete definition on whether these targeted therapies are actually effective or not. But in the meantime, there's a new craze in medical oncology that everyone is talking about and is working and is found to be very effective, and this is immunotherapy. Specifically today, I'll just mention briefly atezolizumab and nivolumab, PD-L1 and PD-1 inhibitors, these immune checkpoint inhibitors. And they are currently enrolling trials in the adjuvant and neoadjuvant setting for renal cell carcinoma with both of these agents. One trial I'll mention is called the MOTION trial. I believe we're enrolling patients here in this trial, or have the capability to, but you guys can correct me if I'm wrong on that. This is looking at atezolizumab in the adjuvant setting compared to placebo. It looks at a higher risk renal cell subgroup. And we're still enrolling patients, so results from a trial like this probably won't be available for many years down the line. Another trial would be the PROSPER trial. This is actually a neo/adjuvant trial where they're looking at nivolumab in the neo and in the adjuvant setting. So the two study arms here would be receiving nivolumab neoadjuvantly, then getting nephrectomy, then getting nivolumab again in the adjuvant setting, compared to just getting nephrectomy alone. Also enrolling patients in this. Now, while this is all very exciting, my one concern that I like to think about with these new therapies is that whether or not we're always going to be, 10 years behind the ball on all these drugs. If you think about these targeted therapy trials that I spoke at depth about, we're just getting the results on these trials, like about 10 years, 15 years after they were standard of care in the advanced setting. And already, while we're just getting these results, we're starting new trials with potentially bigger and better agents. So will we always kind of be 10 years behind the ball, so to speak? That's not necessarily a bad problem. It just seems to be the way things go with regulations and approving things. Just to hop back now to our presentation, to our patient, we had a 63-year-old female who underwent a left radical nephrectomy. Her pathology recently came back as clear cell, firm and nuclear grade 2, and she was actually staged as PT2A, so at least stage 2 localized RCC. Before surgery, she was considered actually to be enrolled in that motion atezolizumab adjuvant therapy trial. However, she's no longer eligible. But it's interesting to note that she perhaps would have been eligible had we thought about it in advance for this nivolumab trial. So just overall, just like the rhetorical question I'll pose is, after reviewing something like this, would you consider targeted therapies? Would you consider trying to enroll patients more often in these new clinical trials? Or would you just leave your management as is until you have more firm answers? And with that, I'd like to thank you all for working with me. And I'll open up to questions. Yeah. Thank you.